Good afternoon. Um, Welcome to this first therapeutic update lecture series for 2020. Today we are having the therapeutic update on non-alcoholic steatohepatitis, and we have got Professor Anuradha Dasanayaka, who is a professor in pharmacology and a consultant physician. He is attached to the Faculty of Medicine, University of Ruhuna, and University of Kelaniya, University of Kelaniya. And he has been working in the area of liver disease, I know, for a long period of time, and has extensive publications in this area. So it is my pleasure to invite my fellow pharmacologist from the University of Kelaniya to give this presentation.
Good afternoon. Thank you very much, Dasani, for inviting me and for the kind words of introduction. So, quite interesting topic and complicated topic, but we have done fair amount of work on the field in Sri Lanka, and I will try my best to do justice to the topic over the next hour or so. As usual, we'll start with the history of fatty liver, very interesting history we have got. This is foie gras, bird fatty liver. It's expensive delicacy of the French royals and aristocrats. Now produced mostly by force-feeding birds. The duck and the geese. The ancient Egyptians first started doing this. They noticed that migratory birds, just before their departure back home, start eating profusely and become very fat, and their livers becoming 10 times as large as the normal liver. And they, after getting those fat bellies and big livers, they fly back home non-stop. The longest track, the recorded distance traveled is from New Zealand to China non-stop 8 days, and it's about 8,000 miles. So till they burn all their fat in their livers, they fly non-stop. So the inference is that you can accumulate fat in your liver very quickly, and you can get rid of your fat also as quickly. Then what happened was that off season, when they wanted to taste fatty liver, the ancient Egyptians started feeding domesticated birds like the duck and the geese. And this which is from pyramid 7,000 years ago, and still preserved at the Louvre Museum in Paris. Then Apicius, the Roman chef, famous Roman chef, wrote about foie gras 2,000 years ago, and the Roman historian Pliny the Elder has written that Marcus Apicius, the chef, would make fatty liver in the bird by feeding these dates and raisins. So now we know that dried fruits are a good source of sucrose. So he fed those with dates and made their livers fat. So now we know that sucrose is very bad for the liver. History of fatty liver in the humans, it was known to occur in diabetics for over a century, but the epidemic started after the epidemic of fast food and production of high fructose corn syrup. This high fructose corn syrup use started as a cheap and cost-effective alternative to table sugar. You know, there was a deficiency of scarcity of table sugar in the 1970s, and this HFCS, the corn syrup, was produced from corn, and that led to an epidemic of fatty liver, and also the fast food epidemic. The fast food consumption started in the 50s. So what are the characteristics of a fast food? So these are the characteristics according to Wikipedia. Prepared quicker than traditional food. So you can prepare them within minutes. Easy takeaway through a drive-through. Relatively cheap, very very cheap compared to normal meal. Very poor nutritional value, and it's harmful and contains processed meat, saturated fats, sugar, salt, and high in calories. And linked to all these epidemics of diabetes, obesity, cholesterol, cancer, and fatty liver. So what are the NAFLD fatty liver milestones? Relatively new liver disease, and people started talking about it in 1980s. Before that, it was just called cryptogenic cirrhosis or whatever. So it's one of those newer liver diseases compared to old, because hemochromatosis, Wilson's, they were known for ages, centuries, perhaps. So probably it was not common. All started after the epidemic of this high fructose corn syrup and fast food epidemic, and this is the person who described fatty liver first, Jürgen Ludwig, in 20 patients at the Mayo Clinic. Then by 1990, we know that NASH was leading to cirrhosis, and probably the main etiology factor behind cryptogenic cirrhosis. And people published that article. Then Elizabeth Brunt was the one who first described the grading of or quantifying the liver fat, and he graded it to 1, 2, 3 depending on various characteristics like fat accumulation, that's the amount of fat, degree of fat, the cell ballooning, and the degree of inflammation and the degree of fibrosis. Then 2004, this experimental drug, obeticholic acid, was shown to be working in rats, right? So that was 2004, and now 2019, after 15 years, that we know that it is working in humans. That's how long it takes for drug development, from animal studies to human studies. So after 15 years, it's known that it's working in humans, and probably within next year it will come into guidelines. Obeticholic acid, it has multiple actions, preventing inflammation, fibrosis, lipid metabolism, on atherosclerosis, bile acid homeostasis, and glucose metabolism. Acts on the FXR receptor. It's quite similar to, not identical to ursodeoxycholic acid, but something like ursodeoxycholic acid. Then 2004, same year, there was a publication linking the improvement to weight loss. So still one of the main methods of treatment. And 2008, Romeo published this article describing the genes involved in fatty liver in the Nature Genetics journal. And even before that, we knew that it is familial, but surprisingly it took such a long time to for them to find evidence for the heritability of the fatty liver. By 2010, vitamin E and pioglitazone trials came out and shown to be beneficial, and by 2015, this great study by Villagomez from Cuba showed that if you lose more than 10% of your weight, very difficult thing to do, you can even think of reversing your fibrosis. So one of those landmark studies, 2015. Then first human study on obeticholic acid in NAFL, a phase 2 trial of the famous Flint study in 2015, which shows that in about 300 people, it's really beneficial in established non-alcoholic steatohepatitis. Then elafibranor, the dual PPAR agonist drug, something like pioglitazone, is still undergoing phase 3 trial, and still the results are not yet out. The study was started in 2016, and 2018 the when it was 2018, there were two more studies, phase 2, phase 3, one on elafibranor, one on obeticholic acid. So if results are okay from a phase 3 study, it's very likely that it will be recommended and will come to guidelines soon. 2019 interim results of one of those trials, the obeticholic acid trial, the regenerate trial, came out, and interim analysis beneficial, and probably results will come out in 2021, full results after 4 years, and very likely to that obeticholic acid available in this country, likely to be approved by the FDA and into guidelines by 2021. 2021. So what is fatty liver or non-alcoholic steatohepatitis or fat-related liver disease? It's a very complicated metabolic liver disease, and in fact it's a multi-system disease. So because we have done fair amount of work on this field from Ragama, these all published data from Ragama. In 2007, there were 33% of adults. This cohort of 3,000 patients we did ultrasound scan, depending on strict ultrasound criteria in 2007. 3,000 patients, 35 to 45, then 45 to 55, and 55 to 65, 3 age groups. And in urban areas around Ragama, 33%. Then we went to the estate sector, and there it was in Talawagale, 18%. When we repeated in the same cohort after 8 years in 2015, and this 33% has doubled. So the incidence has doubled over the 8 years, and now they are elderly, nearing 70 years, most of them. So, and the rates are much worse in diabetes, and maybe almost all of the diabetics may be having fatty liver. And it's the number 1 liver disease in the country, and if you take the transplantation referrals, most of them are, earlier it was alcoholic liver disease, but now it is fatty liver. And if you want, when they want to do transplantation, live donor, most of the live donor patients have fatty liver, so they can't donate when they have fatty liver. And association, we have done it, and it's quite there here in Sri Lanka as well, PNPLA3, and it's the most common cause for hepatocellular carcinoma as well in Sri Lanka, and recurs in almost all transplanted livers, transplanted for cryptogenic cirrhosis. Then some people have non-progressive fatty liver. So they have fatty liver till they die, but they don't develop cirrhosis. It's called non-progressive fatty liver. It's a common fatty liver we have, and they are near zero liver mortality. They die of either heart disease or hypertension or other cause. Their cardiovascular mortality is high, but about 5% of them go and develop NASH or non-alcoholic steatohepatitis, which is going to these people will get fibrosis, cirrhosis, and hepatocellular carcinoma, and the rate of progression varies from patient to patient. And this is a very complex disease process, and we really do not know exactly why this is happening in these 5% of people. And the bad thing is that NASH can progress with normal liver enzymes. So till you develop cirrhosis or hepatocellular carcinoma, you will not know that you are having fatty liver, which is progressive, and this exact mechanism of progression is not still clearly understood. This is what's happening. Maybe fast food, some kind of a toxin, then maybe starting in childhood, and over the years, by the time they develop cirrhosis and hepatocellular carcinoma, you are around 50, 60, 70. So it's a prolonged illness, and each stage may be taking years, 10 to 20 years, from even fibrosis, cirrhosis, and child's A cirrhosis to child C cirrhosis. It's a very prolonged cause of disease, and the good thing is that you can intervene at each step. Even after development of cirrhosis, you can intervene, and that's the only good thing about this. It's a fairly prolonged illness, and probably starts with all fatty food and saturated foods and fructose and other things. Right? Then you may be having other components like inflammation, oxidative stress, apoptosis, regeneration, fibrogenesis, and even genetic susceptibility. And that's why I said only 5% is progressing, and rest of them, their cardiovascular mortality is going to be high. So what are the major contributors? Insulin resistance, lipotoxicity, genetics. Lipotoxicity is where you get some kind of a lipid associated inflammation process starting when you have what's called ectopic tissue. Ectopic adipose tissue is where you have fat, where fat shouldn't be, like the liver, epicardium or omentum. Then this is the new kid on the block, what's called the gut dysbiosis, changes in the gut microbiome. We all have about 2 kilograms of bacteria inside our gut, and changes there triggered by various bad food habits, fructose, saturated fats, antibiotics, bile acids, and various bile acid pathways. So we really do not know what exactly makes your microbiome starts misbehaving, but that's one of those areas for research, and there are a lot of research ongoing in this area. What are the risk factors for progression? Because it's a multi-system disease, you can have other involvement of other organs and systems, and if you have this, then the rate of progression is high. So if you have NASH and diabetes, then your risk of getting cirrhosis is much higher. So real reason we do not know. And on the other hand, if you have fatty liver, your risk of dying from heart attack is also much higher. Probably same illness happening everywhere. So even in the US, what's the plight of these patients? So a lot of them will present, even in the US, the end result is that you will not know till you present with the hepatocellular carcinoma or the first episode of hematemesis or ankle swelling, because it's a silent killer. You will be asymptomatic till you lose 70% of your liver. So even in the US, the presentation probably is the first episode of decompensation, and if you present with hepatocellular carcinoma, that will be the end. But if you present with something like hematemesis, there's time for a transplant. If you present with the diffuse type of hepatocellular carcinoma, probably that's the end of that patient as well, unfortunately. So it's a silent killer. So at the moment, so I made this slide in 2018, but it should be 2020. There are two areas of research at the moment to develop a drug, and the drug, see the drug budget on now, at more than 100 drugs are being tested. The real reason is that now in the US, hepatitis C was the #1 liver disease up to 2-3 years ago. Now there's treatment for hepatitis C. Now they are focusing on fatty liver, because fatty liver has suddenly become the #1 liver disease in the world, in the US. So if a disease is common in the US, drug firms starts going behind that illness. So now there are more than 100 drugs in phase 2 and phase 3 trials dealing on fatty liver, because if you develop a drug, that you are going to be very rich, that drug company. And also non-invasive marker. Now we are going to move away from biopsy to diagnose fatty liver, because you have to start treating, you have to diagnose who is the person who is going to progress into, I said 95% is not going to progress. I am going to catch that 5% and start treatment. That's going to be the idea. So how do you catch a patient who is developing fibrosis? Through non-invasive markers. You don't have to do biopsy, do one of these. And of these, fibroscan and these various scoring systems have come out into the open. So these are the scoring systems. These are very simple, and they are as good as these complex imaging techniques. Just the AST-ALT ratio, AST to platelet ratio, and I am very fond of this FIB4 score. I will tell you how to use FIB4 score and the NAFLD fibrosis score. Now this is the fibroscan, the imaging method coming up big time. Just like an ultrasound scan, you have a probe there and you have a scan machine like ultrasound scan, and then it's a non-invasive 5-minute job, and then you get a report with two values. This 204 or 209 here is the fat quantification, and 3.5 here and 33.3 here, it's the liver stiffness in kilopascals. 3.5 is normal. If it is 33 cirrhosis, more than 12 is cirrhosis, up to 7 it's normal, 7 to 12 is fibrosis, more than 12 is cirrhosis. So 30, this is cirrhotic, this is amount of fat here. So this is one of those, and we have two fibroscans in the country at the moment, one at Ragavan, one in the private sector. Just like an ultrasound scan, very operator friendly. And as I told you before, this is the degree of the stiffness in kilopascals, more than 12.5 cirrhosis, and less than 7 normal, and between 7 and 12 fibrosis, and 9.5 to 5 significant fibrosis. This is the area we are targeting for treatment because fibrosis has started. So if the fibrosis process has not started, then they don't have, or there is minimal liver related mortality. But this starts progressing, the fibrosis sets in, then over the next 10, 20, 30 years, the patient is going to develop hepatocellular carcinoma, cirrhosis and hepatocellular carcinoma. So at the moment, fibroscan will tell you exactly with certainty that there is certain degree of fibrosis setting in. So then more simple serological markers, just check your AST, ALT and the platelet count and the age. Just 4 variables, and you get your sell out and go to the internet and download this FIB4 score or app and just calculate it, and if your average is 3.25, then it's advanced fibrosis. I will give you a few examples of the FIB4 score. If the FIB4 score is 0.56, this is what we see in most of the people now. Age 30, ALT is 80, AST is 40. This ratio is absolutely important. ALT higher than AST is good news. There is no fibrosis. And the platelet count normal, and use that, get the score 0.56 is much lower than 1.45, and this is no fibrosis, and if there is no fibrosis, you don't have to proceed with the fibroscan or any further with a biopsy. And if this is so, repeat non-invasive markers in 2 to 3 years. This is the FIB4 score for a kind of common patient that we see with fatty liver. Example 2, now the patient has aged, ALT has come down a bit, AST has gone up, platelets slightly reduced. So you put that, FIB4 is going to come around 2.17. This is bad news. It is more than 1.45 but less than 3.5. This is fibrosis, and this patient needs a fibroscan, and the fibroscan confirms that there is fibrosis. The guidelines say to do a biopsy and start on treatment. But biopsy is invasive, but still with these two, although it's not in the guidelines, we tend to treat them. This is another example. This is cirrhotic basically. Aging, ALT is lower than AST, AST has reversed now, platelets further down, FIB4 score, then this is established cirrhosis. You do a CT or biopsy to diagnose this. Okay, so what's wrong with the biopsy now? We all, when we were students, we were told that cirrhosis is a biopsy diagnosis, hepatocellular carcinoma is a biopsy diagnosis. But it's no longer true. Why? It's invasive, carries a mortality and carries a degree of morbidity. hospital stay of at least a day or two. It's painful, and the sampling issue is also there. This is not considered not given priority. Only 1 in 50,000 of the liver, so there can be a sample error. And see here, now if you do the biopsy in this area and this area, see the difference. So if you do the biopsy from this area, 60% of the liver is fibrous. If you do the biopsy from this area, only 50. So what it says is, because of this, you can interpret the degree of fibrosis very differently depending on from where you biopsy. So because of that, fibroscan is gaining momentum. Now, say I told you about this microbiome issue and what's happening. So gut microbiome has been identified as a regulator of energy homeostasis and fat deposition. So all those 2 kilograms of gut microbiome is function as a separate organ. So how does it change? Probably saturated fats, fructose, and maybe antibiotics, and maybe genetics. And then these changes in the gut microbiome can lead to production of various bacterial products. And then due to leaky guts, with this production of these toxins from bacterial metabolism, whatever, it tends to leak into the circulation and gets deposited in the liver as endotoxins, short chain fatty acids, and liposaccharides. And then it alters metabolism of the bile acids and leading to lipid accumulation and inflammation in NAFL. So diet, the typical Western diet, aided by differences in the age, lifestyle, genetics, and antibiotics, changes in the gut microbiome, leading to all these NCDs: obesity, diabetes, IBD, fatty liver, cancer, autism. Okay, this changes in the gut microbiome, what's called leaky guts. All these toxins from the changed gut microbiome reaching the liver and fibrosis, leading to cirrhosis. Here, if there are no changes in the microbiome, you get a normal liver. Right, to treatment part, non-pharmacological treatment and pharmacological treatment I am going to deal separately, and treatment of other risk factors also. Non-pharmacological weight reduction, as I said before, low calorie, low fructose, low fast food, and processed food. So we all know that these are dangerous. So all sweets to be avoided, especially commercially made desserts like ice creams, cakes, chocolates, then processed food, and in addition, a low calorie diet for all those people with fatty liver. Even for normal people, I think that's the way forward. Then weight reduction. This is the, as I said, the landmark study from Cuba. So the issue is, if you lose more than 5% fat, the ballooning and inflammation is reduced. If you lose then more than 7%, resolution of NASH, and if you lose more than 10%, reversal of fibrosis. So if you catch someone around this, as I said, the fibrosis stage of between 7 and 12, if you can lose 10% of your weight, it itself can reverse your fibrosis. So how to achieve 10% of weight? Now, according to this study, this is what they did. This tells you better. Yeah. So calorie reduction. This is the study from Villa Gomez from Cuba. 750 kilocalories less than the daily requirement. So daily requirement according to your sex, age, and the job you do, Miffin's and Joy equation. And so if your requirement is 2500 kilocalories, you reduce it to 750. So that's reduced 750, and that's 1750, and go to a dietitian, get a diet chart according to your culture and so on. And then you prepare a daily food diary plus 200 minutes of walking per week, and meeting them to promote and adhere to diet every 6 weeks, 88 weeks. And in this study, diabetics were included, and almost all are white. So unfortunately, none of these studies that I am going to mention has any South Asian or Asian, for that matter, involvement. So we really do not know whether we can extrapolate all this data into South Asian patients. But here all these studies are done in whites. So all were overweight or obese, and because of this vitamin E and pioglitazone are known to benefit these NASH, they were excluded from the study. No vitamin E or pioglitazone were allowed, but statins were allowed. 39 declined a second biopsy, and with all these strict protocol, only 30% achieve a weight loss of more than 5%. And even with these strictest of protocols, 200, some fair amount of could not achieve weight loss, and very few people achieved the target weight loss of 10%. And there were no lean NAFL patients in the study. So why, with the strictest of protocols, why you can't reduce weight? What's the reason behind it? Because obesity is a complex neuropsychological illness. If you become fat, very difficult to lose weight after that. So calorie reduction leads to energy conservation. So that's a major issue here. And after some time you say, oh, no point of calorie restriction because I'm not losing weight. If you start eating normally, you gain weight because calorie energy conservation persists. So that's what they say. I have been trying to reduce weight. I am eating less, but I am gaining weight. That can be true after all, because body has geared for energy conservation, and when you start eating normally again, you gain weight. So that's why people who try to lose weight end up gaining weight. Weight reduction, how realistic is weight reduction? If it is to be realistic, it has to be a multidisciplinary approach. You should have weight loss clinics, specific clinic for this, and frequent monitoring, calorie reduction, exercise, and you can have other helpful drugs like even orlistat and even bariatric surgery. So it's a very complex approach. You need to sustain a weight reduction. So liver physicians, how can they help? I think for liver physicians, it's extremely difficult to achieve weight while dealing with other liver people. I think we should have some kind of a good referral system, or either we have to learn, we have to become a food expert or a weight loss expert, because you have to learn the subject and start dealing with. That's probably one of those one of the two alternatives you have to help these patients with fatty liver. Orlistat is useful but not strong enough, and it's not recommended in guidelines. So there are 2 studies saying that orlistat reduces weight and beneficial in fatty liver, but I don't think it's strong enough to be recommended in everyday use. But in selected people for kind of very smaller degree of weight loss, it can be recommended. Coffee is very well known to be beneficial and in fatty liver, and fatty liver, if you take coffee, it's known that in fact coffee is beneficial in established cirrhosis as well, and one of these recommended alternatives that you have as a drink, because you can't recommend alcohol at all even in safe limits, and the cirrhotics should not be drinking at all. If you have cirrhosis, drinking is out, not even the safe limit, and insufficient data to whether fatty liver, the non-alcoholic fatty liver patients benefit from safe drinking, but advice is to avoid alcohol totally, because these 2 illnesses are very similar. Fructose, the sweet, is a little bit different from table sugar. Aids lipogenesis and blocks fatty acid oxidation and increases production of uric acid. So fructose is very toxic to the liver. So toxic that now people are thinking of what's called fructoholism, like alcoholism. I will show you a slide there. So what are the fructose containing foods? Table sugar, dried fruits like dates, figs, and raisins. Then all these sweet things like honey, kitul treacle, jaggery, then fructose corn syrup, all soft drinks like colas, fantas, cordials, all commercially made desserts. So all commercially made desserts are full of high fructose corn syrup or sugar syrup, which ultimately end up with the deposition of fat in your liver. This is what I call fructoholism. It's like alcoholism. Fructose is a major component of table sugar and of many added sugar syrups, and excessive fructose consumption can lead to addictive behavior, which is called fructoholism. So fructose metabolization leads to hepatic steatosis and cirrhosis, and it's called fructoholic liver disease. This 2019 only this Hepatology, the #1 liver journal, published this slide. And we need global strategies to reduce ingestion of added sugar, education campaign to promote healthy diet, increasing taxes on foods, and some of these things are even practiced in Sri Lanka. So I think the worst thing that you can give your child is commercially available sweets and desserts. What about artificial sugars like sweeteners, aspartame, sucralose, saccharin? What are the data for them? Whether they are beneficial? Apparently they are not beneficial. Stevia is coming to Sri Lanka now. But you can use wisely, but may worsen obesity and diabetes, because may increase the craving for real sugar. You can hoodwink your taste buds, but you can't hoodwink your brain. So whatever you do will, because there's no increase of your glucose levels in your blood after tasting this, and you can end up with craving for sugar. So still jury's on, but I don't think we have any data to comment on artificial sweetness, whether they are beneficial in the long term or not. Bariatric surgery. Bariatric surgery, surely there's weight reduction. Whether you can recommend bariatric surgery for fatty liver, still we do not know. And this is what happens with bariatric surgery. You have a normal gut, normal microbiome diversity. In obese, there's low diversity. So there's a major change in the gut microbiome diversity in fat people. And with these various gastric bypass surgeries and surgeries, there is evidence to say that there are changes in the gut microbiome which transfers from low diversity to high diversity. In fact, the norm. So with gastric bypass surgeries, some of them, your microbiome, gut microbiome become normal. So that can end up with fairly significant weight loss. In fact, at the moment, the most useful method of losing weight is bariatric surgery. So what is the future for bariatric surgery? So how do you justify undergoing such big operation for these people? Morbid obese have limited life expectancy. You have to convince them that if you are, say, 150, 160 kilos or 40, 45 BMI, you are not going to live long. So might as well take the risk of undergoing surgery, and the risk may be acceptable in expert hands and in expert centers. So every year in the US, there are 200 to 300,000 bariatric surgeries being done. And the timing of surgery is important, and you have to do it before development of major medical complications. So ideal age is, if you are morbidly obese, it's around, if you are very obese, think of bariatric surgery around the age of 40, before the development of major complication. Fecal transplant to change the gut microbiome. There are a lot of research going on in the field, but still no evidence to. It's useful in Clostridium difficile or pseudomembranous colitis. That's the only evidence-based indication for fecal transplantation at the moment. But there are research going on by changing the fecal gut microbiome through fecal transplantation, even in fatty liver, but still there's no firm evidence robust evidence to suggest that it's beneficial in fatty liver. Pharmacological therapy, I'm going to concentrate to two kinds of drugs. Currently available medications shown to be beneficial, and that is vitamin E, pioglitazone, and incretins, liraglutide. These are being used for various other purposes. And drugs coming through development drugs developed by the industry. So it's very specific fatty liver drugs, obeticholic acid and elafibranor. I'm going to talk on those two drugs and other drugs which are very useful in patients with fatty liver like statins. So this is where you can intervene. This is the liver, and this corner of the spectrum is fibrosis and cirrhosis, and it all starts with accumulation of lipid in the liver. It's what's called de novo lipid synthesis in the liver, or lipid coming from outside getting deposited in the hepatocyte. So various pathways are being analyzed, and research is on whether you can reduce the absorption through orlistat to PEPA agonists like pioglitazone and elafibranor, vitamin E to reduce oxidative stress, pentoxaphylline to reduce oxidative stress, anti-fibrotic agents like simotuzumab. So all these research is going on still, but I'm going to talk about two main areas. The inflammation and bile acid pathways. Right, okay. So start with the PREVENT trial, where in 2010 by Sunnell from US, they compared vitamin E and pioglitazone with placebo. So both of them were beneficial, vitamin E in non-diabetics and pioglitazone in diabetics. Then liraglutide, incretin, it's a small study. It's a fairly well-established drug in diabetes and proven to be beneficial in a rather small study. Unfortunately, the study was too small to be recommended in guidelines. Then came the FLINT trial, the obeticholic acid trial in 2015. 25 milligrams of obeticholic acid or placebo, and this is a phase 2 trial, 283 patients, and shown to be beneficial, and which led to the large regenerate trial, phase 3 trial, and the results of interim results were published last year in the European Society meeting, and see the improvement in the fibrosis, 38% with the higher dose compared to 23% with the placebo. So that is interim analyzed, and full analysis, end of the research analysis is expected in 2021, and already the drug is gaining momentum, and even we have this drug in Sri Lanka at the moment for high-risk patients. When we feel as if we can't wait till 2021, we have started few patients on obeticholic acid already, not very expensive at the moment. Elafibranor, I'm not going to talk a lot because the phase 3 trial is on. It's something like pioglitazone, and still results are not out, and probably within next 2 years we will see the results. Okay, so these are the currently some ongoing drugs: obeticholic acid phase 3 and elafibranor phase 3. All others are still phase 2 trials. Okay, last few slides I'm going to concentrate on statins. So statins and the liver. So it's a huge topic now. Statins have pleiotropic effects: anti-inflammatory, anti-angiogenic, and anti-fibrotic effect. So it should have some beneficial effects on cirrhosis. Statins are remarkably safe in liver disease and should be used if indicated. statins will safeguard the coronaries. One of the main reasons that we need statins in this people is that when the cirrhosis patients develop decompensation, then in need of a transplant, we can transplant them because they have coronary artery disease and kidney disease. So we need the kidneys and the coronaries in good shape for them to undergo a transplant, because they need 8 to 10 hours of anesthesia for liver transplantation. So as most of these cirrhotic patients have metabolic syndrome and concomitant diabetes and coronary disease, they automatically become poor candidates for liver transplant. One of the reasons why all these NASH patients or fatty liver patients should be on a statin from the beginning is that in a way it helps the liver as well, because a lot of studies are coming out that it's beneficial in liver disease, both fatty liver and decompensated cirrhosis. And at the same time, we need their coronaries in good shape for them to have a transplant. So statins may delay decompensation and hepatocellular carcinoma in patients with early cirrhosis. If someone asks me what's the drug that you give a patient with compensated cirrhosis, my answer would be statins now. So statins, like in coronary artery disease, is going to be hugely beneficial in patients with advanced liver disease. But unfortunately, they have not been tested adequately in NASH, comparing it with other drugs. So treatment with statins, definitely safe in non-alcoholic steatohepatitis and compensated cirrhosis, and the evidence to suggest that there's dramatic decrease. I said it's anti-angiogenic and anti-fibrotic. Dramatic decrease in hepatocellular carcinoma in patients with type 2 diabetes mellitus on statin. All these epidemiological studies, and less severe NASH and dyslipidemias on statins, and improved liver function test in some cases. So if there is indication of statin, please use statin in non-alcoholic steatohepatitis even if the enzymes are marginally raised. What about the guidelines? We have an issue with guidelines. So we have three main guidelines to direct our treatment of these patients. One, the American guidelines, the one European guidelines, and third one is Asia Pacific guidelines. None of them, both American and European guidelines, they recommend their recommendations based on studies from Europe, and as I said, most of these studies are on white Caucasians. Because of that, the Asia Pacific guidelines generally do not consider them as representative of Asians. It happens to, I think, cardiac drugs also. So I think our NASH is different, and at least one study to say that our fatty liver, so our cirrhotics are more, our cirrhosis, NASH is more aggressive and occur at a young age, and our rates of hepatocellular carcinoma are high. So I think our cirrhosis is different from what we see from the West. So unfortunately, we don't have a lot of studies on them. And so the guidelines recommend vitamin E patients who are non-diabetics and who have a proven NASH in the biopsy. So most of our patients are diabetics and they don't have a biopsy. So then are we going to withhold vitamin E or obeticholic acid in patients? So if we treat them with them, then it becomes off-label treatment. So is off-label treatment is a crime? No. Because even in the US, 20% of all prescriptions are off-label, and even the people who write those guidelines recommend these drugs in their clinical practice. So what we say is that even if the guidelines say start vitamin E in a patient who is biopsy proven NASH, who is not a diabetic, and what I say is that if the patient is progressing to cirrhosis in front of your own eyes, might as well treat them with vitamin E or obeticholic acid, even if it is not recommended. I may be wrong, but that's what I feel, because if we stick to guidelines, we can't treat 90% of our patients. Okay, so what happens if you see a fatty liver patient? If you detect a fatty liver patient on ultrasound, or if you see a patient with elevated liver enzymes, what are you going to do? It's a good algorithm from hepatology, right? So if you have elevated liver enzymes and if you don't have symptoms, what you should be doing is to you take it as asymptomatic elevation of liver enzymes, and you rule out all other liver diseases like hepatitis B, hepatitis C. Patient is young, Wilson's disease. If the patient is a female, male autoimmune screen, and all these are negative. Ultrasound scan says fatty liver. You treat it as fatty liver, and then you start them on lifestyle modification. If the liver enzymes come down, you can presume that it is fatty liver, and then you can go for FIB4 score. And FIB4 score is high risk, then go for fibroscan and that pathway. If you have ultrasound evidence of fatty liver, liver enzymes the same pathway, liver enzymes are high, liver enzymes are normal, you take this pathway and correct the risk factors for obesity, diabetes and dyslipidemia. According to these guidelines, all type 2 diabetics also should have their liver enzymes and ultrasound scan examination to rule out NAFL. In our guideline, in Sri Lankan guidelines, they do not recommend screening for type 2 diabetes for fatty liver, but they do recommend for all other illness like eyes, legs, kidneys, ECG, but not the liver. I think even our guidelines, fatty liver should be included, because we are losing a lot of patients because we cannot detect their liver illness in time until they present with the hepatocellular carcinoma. Then little bit of liver transplantation, how difficult or easy for us to transplant these patients when they have fatty liver. As I told you before, they are not good liver transplant candidates because they are obese, they have diabetes, they have kidney disease, they have bad coronaries. So generally they are not good transplant candidates, but unfortunately they are the majority. So what can be done? So detect them early and make sure that, say, if you detect a cirrhotic who is going to need a transplant in 5 years, attend to those risk factors early, so that keep their heart and the kidneys and the BMI and the things in good condition for them to undergo liver transplantation. And it's major obstacle for cadaver donor programs because fatty livers are poor graft survival. If you get a liver from a brain dead patient, either patient is obese or taken alcohol, and he already has a fatty liver, the donor, the brain dead liver, and it cannot be transplanted, because if you transplant a fatty liver to a recipient, it has very poor graft survival. And even in live donor transplant programs, if you have a fatty liver, very lower chances of graft survival, or we generally do not take fatty livers for transplantation, even for cadaver, nor for live donor transplant programs. And in the transplanted liver, almost all of them develop NASH, but unlikely to be clinically significant. As I told earlier, it takes 10, 20, 30, 40 years to develop fibrosis and decompensate. To summarize, ladies and gentlemen, Chairperson Madam, progressive fatty liver is mostly food related, and the gut microbiome and genetics play a major role. Energy, excess is the key. Fibrosis stage predicts survival. So 95% will not progress, about 5% will progress, and the progressing 5% you have to detect early and start interventions. Lifestyle modification is the key, as I said, diet and exercise basically. 10% weight reduction is going to reverse fibrosis, but few can achieve it, unfortunately. Pharmacological breakthrough is close by and probably already there. Obeticholic acid is the front runner, expected to be recommended within next year or two. Statins have a major role to play, but appears underused. International guidelines, statements and guidelines appear inadequate, at least in our setup. So how to treat bird fat liver? Ask them to fly non-stop for 7 days. And this is what we have to tell at the end. Thank you very much for kind attention. I'll take some questions, please.
Thank you very much, Professor Anuradha Dasanayaka, for that excellent lecture. Actually, when I proposed this topic, therapeutic update on non-alcoholic steatohepatitis, I was in two minds as to whether for a therapeutic update, whether there would be sufficient amount of things to talk about. But I think you have proved me, dispelled all those doubts. You have really, I learned a lot. So there are a lot of new things coming up, and so I think you have really, educated all of us. I'm sorry that the postgraduates are not here, because I think there is another neurology update which is happening in the hospital. So therefore, most of them are here. But I'm happy that we have the recording so that we can at least update it. So I'm sure you will be happy to take any questions.
Yes, sir.
I'm Dr. Girakodi, gynecologist. I learned a lot. So when professor says she learned a lot, that says something. And absolutely fascinating lecture. And I think you should really get it out to the public. So a lot of doubts and questions and misconceptions. Two things I want to ask you really about. You normally with diabetes you say sucrose is bad, fructose is good. Stick to the fruit sugar, but we are turning it upside down. But the more important question I have to ask is about genetics. Now, supposing you diagnose a fatty liver in a parent, is it possible to test the children so that you can catch them early? It may be too late for the parent, but at least you must save the next generation. What are the possibilities?
Yeah, two questions I'll answer separately. The first question about the fructose. What is bad is not the entire fruit. Commercially produced artificial fructose from corn syrup, or the juice without the fiber produced from a fruit. So cordial is bad.
Oh, I see.
Cordial is bad, but not the mango itself.
Right.
So mango juice is bad because we have thrown out the fiber.
Right.
So with the fiber, there's no harm. I don't know if you eat 10 mangoes, I don't know what's going to happen, but say what is the entire fruit is supposed to be good, but not the fructose commercially made, because fructose is apparently cheaper and sweeter than sugar. Because of that, all commercially available sweets, sweeteners and desserts are produced from fructose. High fructose corn syrup is produced from corn, but it is much cheaper than cane sugar. Firstly, the second question, the genetics. Yes, now what we do is that, say, even yesterday we saw the fourth person in the family with the hepatocellular carcinoma, all NASH. The three elder brothers are dead, then fourth came with the hepatocellular carcinoma at the age of 60. All of them had got it at the age of 60, 58, 60, 62. At the moment, that PNPLA3 gene testing is not commercially available. What we do is that, say, even for that patient, I told them to come with all your, all four brothers get together. Children get together and come here. At least start this stuff from the beginning.
Yes.
So first thing is to detect cirrhosis. Now FIB4 score, the very simple liver test and the platelet count and the age will tell you whether you are at risk of fibrosis. If you are at risk of fibrosis, there are things that you can do. Weight reduction and start a drug, start a statin. Then all these stages go on for years, more than 10 years. From NASH to fibrosis, 10 years. Fibrosis grade 1 to fibrosis grade 2, another 10 years. So in fibrosis to cirrhosis, child's A, another 10 years. So child's A to C, another 10 years. So we have enough time to intervene, and when you develop cirrhosis, we have enough time to get ready for a transplant. And then when you have child's A cirrhosis, you start screening them for hepatocellular carcinoma. the main cause for death is decompensation and the cancer. So decompensation, you get ready with a liver transplant. For cancer, you do scan them every 6 months to catch it when it is small, like 3 centimeter or 2 centimeter. Then you can either chop it off or can burn it with microwave ablation, radio frequency ablation, TACE. It's a lot of things that can be done for cancer. So only best is to get their children to a good person who is handling these patients, and I'm sure they can be saved. Yes,
You mentioned about coffee is good for this condition. What about tea? There are so many green teas available in the country.
Madam, no evidence for green tea at all. In fact, green tea can be, it can produce a drug-induced liver disease. There's no evidence for green tea. Evidence is there for coffee.
Not for normal tea also?
No, not for normal tea, not for green tea.
Because I had to congratulate Anuradha, it was an excellent lecture, and like Dasanayaka, I used to learn a lot.
Thank you, madam. Thank you, madam.
It was like the whole thing, condensed to 1 hour. It was excellent.
It has become like, madam, earlier syphilis. You told us that if you know syphilis, you know medicine. Now it's like that. If you know fatty liver, you know medicine.
One other question.
Yeah.
You mentioned about statins.
Yeah.
Any particular statin and the target or the dose that we have to look at, or the cholesterol levels that we have to look at?
Well, I think we have to stick to the lipid guidelines that we have. So we have certain target levels for diabetes. So very easy, because almost all of them are diabetics, so you can stick to diabetes guidelines. The issue is that people were not using them in diabetics because their liver enzymes are high. So that's the case. So we should be starting statins on all these diabetics who have elevated liver enzymes, because what's called the drug-induced, the statin-induced idiosyncratic liver illness, so the DILI, drug-induced liver disease, happens in 1 in 10 million. So it's very extremely rare. On the other hand, if there's 100% mortality if you have cirrhosis. It's worse than cancer. It's 100% mortality. Child cirrhosis not going to live more than 1 year.
What about use of ursodeoxycholic acid?
Sorry, madam, there's absolutely no evidence for ursodeoxycholic acid. You have evidence for ursodeoxycholic acid only in primary biliary cirrhosis. That's the only illness where there is evidence for ursodeoxycholic acid. And also pregnancy, pregnancy-induced cholestasis. Yeah.
So now when we have patients with stage 1 and stage 2, apart from diet, exercise, weight reduction, we give vitamin E. After that, statins. And that is that enough, and just follow them up, observation of liver function, and scans every 2 years or so? What do you recommend?
Yeah, madam. Now this is for a grade 1 fibrosis or cirrhosis.
No, this is NAFLD.
Right, okay. NAFL, now the grading given by the ultrasound, grade 1, grade 2, grade 3 is not enough for management. But you should have this grading system which is based on the histology, which is closely mimicked by this FIB4 score, the score that I told you, and the fibroscan. We need the FIB4 score and the fibroscan to tell whether the fibrosis has set in. If the fibrosis has set in, then you have to go for this weight reduction plus vitamin E, or the new drug which is available, obeticholic acid, and then follow them up.
This is a physiological question. You say the bird's liver can absorb fat very quickly and get rid of very quickly.
Yeah.
Humans don't seem to be able to do that.
They are unable to do it. Now, if they lose weight by bariatric surgery, you lose your liver fat. But people, it's a complex neuropsychological obesity. So when we have food, now the birds, when they start flying from New Zealand to China, on the way for 8 days, they don't have food. They can't eat. So if you go to a place where there's no food, we lose your liver fat. But only thing is, when food is around, we just can't help it. You start eating.
Now progression of NAFLD without alcohol.
Yeah.
Right? I always advise my patients, don't drink alcohol, because I don't know if my percentages are right. I want you to correct it. I say about 10% NAFLD will develop cirrhosis by the, NAFLD per se, and if you drink, it goes up to about 25%.
Yes, ma'am. Yes, I agree with you.
Right, no?
Yeah, I agree with you. Because they probably then two diseases coming together there. Then the alcohol also increases liver fat content, and already you have got fatty liver already without alcohol. Then probably two diseases coming together, and progression is going to be much worse. That's why you said no liquor at all for these people.
Can I ask a few questions? Yes, again, brilliant presentation. One thing is,
obeticholic
acid.
Yeah.
Is it registered in Sri Lanka? And is there a registered indication for it?
Yes.
Okay.
Yes, there is the registered indication at the moment is primary biliary cirrhosis.
Okay.
It's registered.
Right.
Obeticholic acid, now this drug was the first Flint trial. The phase 2 trial results came out in 2015. The results were so the data. I mean the because of the robustness of the drug, people started using it like vitamin E from 2015 because there's no other alternative, right?
Yeah.
Then 2019, the phase 3 trial, interim results came out. Then drug was already around because it was registered for PBC.
Yeah.
Then people started prescribing it for fatty liver. That's what happened.
Yeah, so I think we should get it registered here if it is not registered.
I don't know.
Yeah.
I think it's already there.
Already there.
Yeah.
Right,
5 milligram tablet is 60 rupees.
Right.
So 10 milligram dose 120.
Right.
And if you use the 25 milligram dose, it costs about 300 rupees.
Okay,
But for a person like that, family
Yeah.
history of cirrhosis and cancer, I think for the child, it's a
Yes,
drug.
that's right. Then secondly, vitamin E.
Yeah.
Why do you think there are no clinical trials? Because I think as of now, there is no registered indication for vitamin E.
Yeah.
Right? So why aren't people doing clinical trials? Because there are some studies which have shown actually there are some side effects. So I'm just wondering whether people are not really the people are happy to have it like any way you give it because it's a vitamin, and suspecting that there may be any
The answer is that the PIVENS trial in 2010, it was a phase 2 trial, 300 patients.
Okay.
Right? I think the results were not strong enough for them to go for a phase 3 trial.
Right.
Because it was not, the NASH improves but fibrosis was not improving. But with the obeticholic acid, even fibrosis stage improved.
Right.
Secondly, it may be such a cheap drug, no pharma company wanted a phase 3
Phase
trial
3.
from it.
Yeah.
That may be one of the other reasons. Because all three drugs, the drugs which were present at the moment, which were being tested like pioglitazone, vitamin E, and liraglutide, never went into a phase 3 trial. The drug came from the industry, went for a phase 3 trial.
Okay.
That may be one of the reasons.
So do you recommend pioglitazone as well as liraglutide for patients with
Patient
NASH?
who is, so say if you take a diabetic who has NASH, you can go for those two drugs. But not a NASH patient without diabetes.
Yeah. Right. So it's like one of those recommendations if considering the comorbidities.
Yeah.
Over another one,
Yeah.
you can consider. One more thing, this low platelet count, is it related to the fibrosis and hypersplenism?
Yeah.
Right. So that's
Very sensitive platelet. These AST, ALT and the platelet count. Absolutely sensitive. One positive 500 rupees.
Okay.
But it's almost equal sensitivity to the fibroscan to detect fibrosis early.
Right.
Very robust evidence for that FIB4 score.
So fibroscan can be done in your center now?
Ragama there is one, and in the private sector there is one.
Navalok has.
Navalok has.
So with the fibroscan, you don't really need to do biopsy.
No, madam, no.
And at what stage of time, do you progress from vitamin E to a statin?
Statin, madam, from the beginning. If there is an indication from the beginning, because if you now the amount of research going on in cirrhosis, established cirrhosis with a statin, because it retards progression. like what's happening with captopril, and you can remember 20 years ago when captopril came to the market, what it says that it improves survival in heart disease. At that time, digoxin was the drug, but it was not prolonging the survival. But then came captopril, then carvedilol, then aldactone, spironolactone, and so on. The drugs came which improve survival like that. Statin is going to be the first drug probably going to improve survival in established cirrhosis. A lot of trials are going on with statins.
Of course, really, we always, before we start studying, we tell them do left it, because now if this SGPT goes up more than double, they will tell them to stop studying or reduce the dose.
That no longer valid. Now what they say is you test the liver enzymes if you become symptomatic.
Otherwise, you don't.
There's a lot of actually, I think, misconceptions about liver enzymes and statins. Yeah,
because it raises liver enzymes on, due to some physiological reasons. No liver damage. So, say it raises liver enzymes, say 1 in 100, but damages the liver in 1 in 1 million, something like that. So you test your liver enzymes if the patient becomes symptomatic. Otherwise, you are going to stop a statin in a patient who really deserve it.
And this transient liver enzyme elevation apparently comes down.
It comes down with use.
When it continues.
It's going to. That's why I said don't test it, because if you test it, you get scared and stop it.
And I think there aren't any cases of definite liver failure which is linked to statins.
No. There are two. There is one case with simvastatin, one case with atorvastatin, none with rosuvastatin. That's of the currently used drugs. There may be one case each for simvastatin. That's about how many prescriptions? 1 in billion.
And that also, what I have read is there could be some other confounding factors which were contributory.
Yeah.
Definitively that you can identify linked to a statin.
I went through a DILI registry in the US.
Okay.
So it gives you all the possible deaths related to drugs. So there's one case for simvastatin, one case for atorvastatin. That's all.
There are some people who do on the social media all the time. So they say the statins are bad, your brain gets atrophied, this and that. So there are some people who even stop statins because of this social media, So
I think still
very good indication of statins.
Yes, I think still on the brain, because there are some links to like dementia and so on.
Diabetes also.
Yes, and certainly diabetes. Which are, I think diabetes there is some evidence, but dementia again there is no, because some studies show that dementia is reduced, some studies show dementia is linked to statins, but so there is no definite evidence. But I think liver disease, of course, there is clear evidence that it is protective. So we should actually promote, I think, as you quite rightly said, giving statins to patients with fatty liver. I think we had an excellent lecture followed by another excellent discussion. So I'm very thankful to Professor Anuradha Dasanayaka for educating all of us, and I'm happy that we have recorded it so that it can be made use of. I think we should, publicize that this excellent lecture is available for people to watch through the video link. Thank you very much, Anuradha. I have the.
Thank you.